Good afternoon, everyone, and welcome to today's PHO Rounds presentation on maternal mortality in Ontario, Partnerships for Awareness and Prevention. My name is Ruth Repchuk. I'm an applied public health science specialist at Public Health Ontario, and I have the pleasure of moderating today's session. I'll begin with a brief land acknowledgement. I'm currently tuning in from Hamilton, Ontario, which is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. This land is covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and the Anishinaabeg to share and care for the resources around the Great Lakes. It's now my pleasure to introduce the speakers for today's session, Dr. Anne Sprague and Dr. Louise McNaughton-Filion. Dr. Anne Sprague has extensive experience in maternal child care and research at regional, national, and international levels, and was the founding scientific manager of Born, Ontario. Currently, she's a project advisor for Born, focusing on maternal and infant morbidity and mortality, while mentoring research team members. Dr. Louise McNaughton-Filion has been the regional supervising coroner for Ottawa's East Region since 2013. Previously, she served as an investigating and inquest coroner and has practiced medicine since 1990, specializing in emergency care after moving to Ottawa in 1993. She's held various administrative roles at hospital, regional, and national levels, and also organizes the multidisciplinary death investigation rounds and chairs the Maternal and Perinatal Death Review Committee. So with that, I will pass it over to you, Anne.
Thank you, and thank you everybody for attending today to talk about maternal mortality, a subject that is certainly close to our hearts at Born, Ontario, where we really exist to facilitate and improve care. So maternal mortality is something that is devastating to both families and care providers, and so anything we can do to improve that is important. And so it's not something that you can do alone. It involves partnerships, and we're here to talk a little bit about that today. I'm just going to start by just this disclaimer that says, Public Health Ontario is not the owner of the content. Louise and I have put together the content with our partners, and PHO assumes no liability for that. So the objectives of today are to describe the role of Born Ontario in surveillance and prevention of mortality, describe the role of the coroner as well, and the work that they do. We'll talk about prevention strategies that are underway in Ontario, and we're going to outline areas, most importantly for you folks, where public health certainly could play an important role in prevention. We'll talk about prevention strategies today, and we'll talk about what both the Born and the Coroners Group is doing. And we believe that step one is awareness. And so awareness means knowing the numbers. And here's the answer to the first poll question. When we did the 20 years of surveillance, looked at the 20 years of data, which I'll describe in a little bit longer, there were 485 maternal deaths. There's likely more that we haven't captured. And then Louise's group, her team has looked at a death investigations, and she'll describe the difference about why our numbers are different. We look at a little bit different things. Step two, we believe, is further study in working groups on major risk factors. And we'll be talking about obstetric hemorrhage today, and Louise will be talking a little bit about some of the major risk factor problems that they've found. Step three is about understanding the morbidity that precedes death and developing provincial and regional strategies for prevention. Experts believe the vast majority of maternal mortality is preventable by better risk management, use of clinical practice guidelines, good communication, and most importantly, learning from previous cases and implementing safety strategies and recommendations as a result of what we learned, so that what happens in, for example, Hamilton today shouldn't happen in Ottawa tomorrow, because we should be able to learn from what's happened. And Louise's group has been sharing some reports and clinical vignettes, the latest one in November 2024 of the JOGC journal, where they looked at a little bit about cardiovascular complications. So quality improvement strategies and projects are getting underway, and we'll want to talk a little bit more about that. But what we have learned is that both groups really need to have better data collection regarding social determinants of health and EDI variables. So this was the paper that we published just early last year. And this was our look at 20 years of childbirth in Ontario and looked at temporal trends and causes. And what we did in that study was a retrospective cohort study of hospital live and stillbirths. We linked the BIS, the Born Information System, to the CHI DAD for hospitalizations and the CHI NACRS for emergency room visits. And we did some, both probabilistic and deterministic linkage to put all those systems together. Many of you who work in epidemiology would be familiar with this. We did exclude home births and birth centers because they don't send their data to CHI, but we're fairly confident that we still have any deaths that would have been associated with that, because most of those people would be transported to hospital when problems began either at home or in a birth center. We did exclude deaths where there was no delivery, and we looked at both early and late deaths. So early meaning up to 42 days, and then late being the full year. And the primary cause of death was reviewed by at least 3 clinicians, and we consulted with 3 others when we had a few discrepancies, when we couldn't quite figure out. Administrative data is sometimes a little tough to figure out, so we had to dig deep sometimes. So here's a review of the key findings from our study. So over the 20 years, and you'll see I'm reporting maternal mortality ratio. And a ratio, the denominator is live births, whereas a rate, which you read about in the literature as well, the denominator is number of women of reproductive age. So, we had the birth data. So over the 20 years, you can see, almost 2.8 million live and stillbirths, and there were 485 maternal deaths. That gave us a maternal mortality ratio of 17.5 per 100,000. So we looked at both the early deaths and the late deaths, as you can see, 222 and then 263. And you can see the MMR of 8 for the early deaths. And the early deaths are what's most often reported in the literature. However, looking at the late deaths is important as well, and a little bit higher maternal mortality ratio. But if we only looked at early deaths, we'd miss some important things about those 263 deaths, of which 13 were pregnancy related, and 250 late deaths that may have had some association with pregnancy. So, as you know, every system changes in pregnancy, and people's mental health, injuries, cardiac, whatever it is, and I'll talk more about it later, can change as a result of the pregnancy and may have had an association with those deaths. In Ontario, our maternal mortality ratio for early deaths is similar to other high-income countries such as France and Italy, but higher than, as we always hear, the Scandinavian countries, the Denmark, the Norway. And we know we're likely underreporting a bit, so ours may be higher. Interesting, though, the US, if you're interested, their maternal mortality rate is 18.6 per 100,000 in 2023. So they have some other issues that they are working on as well. So if we look at this now, this is maternal deaths by fiscal year. And just to give you an example, so the mean number of deaths per year is about 24.25. And so that's 24-ish people young, relatively healthy people who die. And that's, it's a terrible tragedy. The mean age of those people who die is 31, obviously a bit older, a bit higher as your age increases, but still, these are all people relatively less than 40 years old who die. There was no change associated with COVID. There's higher rates, of course, in the most materially deprived neighborhoods, and we're learning that about almost everything that relates to health. So health equity is important and is receiving more attention. This is important, the mental health issues. That 24 of the early deaths and 50% of the late deaths reported at least one mental health concern during the pregnancy, and I think we're seeing a higher profile, that's receiving higher profile in media, in the literature, and in hospitals. Everybody knows this now. This is consistent with the US Joint Commission, which reported at least 23% of their maternal deaths were related to mental health concerns. The UK, it was 40%. Most pregnancy-related suicides occurred postpartum, and 62% of them were after 42 days. And in our study, the median time to suicide was 220 days. That the most common cause of the 169 early of the early and late pregnancy related deaths was hemorrhage. And there were 46 cases of people who died as a result of a hemorrhage. And I'm going to talk more about hemorrhage in a few minutes. But what's interesting to know about these 46 hemorrhage cases is that 25 of them died on day 0, or the day of the delivery. 13 of them were the next day, the next 2 days, and then 4 were on days 3 to 6, and 4 were days 7 to 42. So infection is important, and we learned a lot about group A strep being a major cause of infection. And I know Louise's group a few years ago issued a report looking at sepsis related to death. And in fact, one of our colleagues at a large hospital said that, they implemented quite an important quality improvement strategy on group A sepsis and sepsis, and it has decreased since then. But we need to look a little bit further at that. Interestingly, with infection, the vast majority of people died later, within sort of 7 to 42 days was when people died of infection. And so you can see that the trajectory of what happens with treatment. With preeclampsia, which is, a complication of pregnancy, again, most people died a little bit later. So it's the hemorrhage is, the immediate blood loss problems are what leads to death. And then the various other things: pulmonary embolism, cardiac deaths, amniotic fluid embolism. For those of you who don't know, that's, when the amniotic fluid gains access to the maternal circulation, and that can get up into the heart and pulmonary vessels and cause a major cardiorespiratory collapse. This cardiac arrest is a problematic category for us. It was sort of a catch-all when it wasn't well coded in the system. People would put cardiac arrest, and of course you die if your heart stops. So we need to work a little bit more with data contributors to figure out why that is the catch-all, and what could be cases that they're not collecting, that would be better. And then various others ones that we had. The timing of deaths by weeks following birth, and this is a bit harder to see, but look at that blue line on 0 days, and really what we're seeing here is the 169 deaths that were deemed pregnancy related generally tended to happen within the first few weeks, and whereas the 289 deaths that were not pregnancy related spread out pretty evenly across the board. And then in terms of the non-pregnancy related early and late deaths, we were surprised at how much cancer was there. So 95 cases of cancer in the earlier and late deaths. Infection, there were 31. Injuries, 45. And interestingly, of the 45 injuries, 24 of those 45 were intentional, including assault and suicide. So certainly work to do. And as we've been hearing the news about domestic violence and intimate partner violence, certainly I think we're seeing of that. So just some information there. And so knowing that obstetric hemorrhage was such a big issue, we dug a bit deeper into that. And 9.5% of the 485 total deaths were associated with an obstetric hemorrhage. And that was the largest contributor to the early deaths. As I mentioned, most of them happen within days of delivery. And prompt recognition and management is key to the prevention of morbidity and mortality. And so risk assessment, special codes to get help quickly within hospitals, hemorrhage carts with all supplies readily available. So there's lots of quality improvement work that could be done in this area. But getting help early and recognizing that that blood loss is a problem, having good ways to document blood loss. We know that visual assessments are not good. They're fraught with difficulty. So having more objective methods is important. So learning about some of these things, there's currently a multi-pronged approach underway in Ontario. Cascade events always precede death. So what can we learn about it? And so the CANOS group, the Canadian Obstetric Survey System, led out of the group in Hamilton, is working now and has a number of projects ongoing. They're actually having a summit next week to plan prevention efforts for CanOS Ontario, and I've left a link in there for those of you who may be interested. Hemorrhage, also important, was that 39% of hemorrhage deaths were in quintile 5, or the most deprived groups, versus 6.5% in quintile 1. All but 2 were singleton pregnancies. The mean time to death for hemorrhage was about 1.3 days. All of these deaths happened for people who lived in urban areas. And the mean gestational age was 37 weeks at the time of death. So this is not published yet. We currently have a manuscript in review for this. So we expect to have more information and dig a little deeper into this as we go. But really looking forward to working with our partners to see what we can do in Ontario to really, this should be mostly preventable. And so although, obstetric hemorrhage can be a fast moving, difficult event, there are ways that people can work systematically and use guidelines to reduce the risks of that. So just to finish up my part here, just to give you a little bit of more about obstetric hemorrhage deaths in Ontario. There's still 14 cases. We don't know why the major cause was. So again, we want to improve data collection in those areas. Amniotic fluid embolism, as I described a few minutes ago, it's largely unpredictable, but there is clinical practice guidelines to deal with that, and when you recognize it. And you can see placental abruption. That's when a piece of the placenta comes away from the uterus prematurely, and those blood vessels can't clamp down, and so people bleed. Rupture of the uterus can happen. Atony of the uterus, meaning the uterus doesn't contract properly, usually postpartum. It becomes boggy, it doesn't contract, and there's bleeding. A ruptured ectopic pregnancy, placenta previa, when the placenta is implanted in the lower segment of the uterus, and then when the cervix starts to stretch, and it can cause bleeding. Terminations, when things go wrong that way. High vaginal lacerations and procedural injuries are all cause of obstetric hemorrhage. And then, I should say that of the people who died from obstetric hemorrhage, most of them, about 80%, had a live birth. So, there's families that are left very fractured as a result of this. This is timing by death of obstetric hemorrhage, and you can see, again, we have in interpartum hemorrhage, most die on the day of delivery, versus postpartum hemorrhage, people die after delivery. That makes sense, but it just, there's a period of time where you're trying to get the hemorrhage under control, and then there's multi-organ system failure and things like that. And so people end up in an ICU environment. And this was interesting for us. We looked at day of the week, and you can see here that Sunday and Monday have the highest rates of death for obstetric hemorrhage. And in the days of the week and time, it's pretty even split. 46.1% died during daytime hours, and 53.8% died during evening and nighttime hours. Our hypothesis or our questions that we asked was whether bleeding gets addressed as promptly on weekends, when people might have to be called in, when there's not the same level of staffing, when emergency rooms tend to be more backed up. So we don't know the answer, but it was an interesting finding for us to look at. And so now I'm going to pass it over to my colleague, Louise, who will tell you a little bit more about what the Coroner's group is doing. So I'll move it to you, Louise.
Thank you very much, Anne. So it's a pleasure to speak to all you folks about the Obstetrics and Perinatal Death Review Committee. And I'm going to put another layer on top of what Born has told you. So some of the stuff that she's got is also what we have as part of the coroner system, the death investigation system. So we're going to go a little bit further into a few other areas instead. We do not have a website for our latest report, but the email address where you can obtain a copy of our latest annual report is right there. And I think you'll find it quite interesting, particularly after we talk a little bit about what we found. So the OPDRC, the Obstetrics, Perinatal and Death Review Committee, has been around for over 30 years. It is part of the death investigation system, and the coroner's motto is, "We speak for the dead to protect the living." And the point of this is that in this committee, we look at every pregnancy-related death, well, every pregnancy death, and every death out to a year after the pregnancy has ended. So whether that pregnancy ends with a stillbirth, an ectopic, it's be related to a termination of pregnancy, or whether there is a live birth at the end, we look at those deaths during pregnancy. And again, as I said, a year out. When you're looking at the data here, we'll talk a little bit more about it, but it wasn't until 2023 that we expanded the period of postpartum where it's a mandatory investigation. Up until 2022, we went up to 42 days, which is what's on the death certificate, and is recognized for the maternal mortality rate and the rest. And then we decided, along with the CDC and quite a few other countries, to move it out to a year because, as Anne has told you, there's a lot of preventable deaths that may be related to pregnancy, although maybe not directly A to B. So the goal of our death review committee is to review and identify individual or systemic factors that can be changed, to make effective recommendations either to specific persons or to institutions in order to prevent deaths in the future, and also just to raise awareness overall. Now, our numbers here, 244 deaths reviewed. That's during pregnancy, during the postpartum period, and some selected stillbirths and neonatal deaths. We don't look at all stillbirths and neonatal deaths. In fact, it's a very small percentage we look at. We look at the ones where we believe it might be a preventable death or a preventable stillbirth or a non-natural event was related to it. So here are the people that are on our committee. And when we have a death that we're reviewing, we look at the one that's most appropriate. So if we have a cardiac death, we ask the obstetrical cardiologist to have a look at it. If it's a person who's been followed by a midwife all throughout their pregnancy, we ask for one of our midwifery colleagues to do the review. And as well as the experts on the committee, we also have members of BORN. So Anne's group, the Canadian Obstetrical Surveillance System, is connected with us, Society of Obstetricians Gynecologists of Canada, and the Provincial Council for Maternal and Child Health, as well as a few others. So it gets reviewed as an individual, then it gets brought to the group, and we discuss what type of recommendations could prevent deaths in similar circumstances. So now let's look at the numbers, what we have from Ontario in the past 10 years. So Anne was talking about 20 years. We're just looking at the past 10 years that we have complete data for. So 92 deaths during pregnancy in Ontario from 2013 to 2022. And you can see that we're looking at all of them. If we miss it, if somebody doesn't call it in, the registrar sends us the death certificate, because there's those little boxes in the death certificate that says, has there been a pregnancy? Are they up to a year postpartum? And if those are checked off, they get sent to us. And if they see diagnoses that sound like they're related to pregnancy, they send to us to review as well, if there's no coroner signature at the bottom. So looking at the numbers, you can see that around half are natural deaths in pregnancy. 25% are accidental deaths. And I can tell you 80% of those accidental deaths are substance use toxicity. The number of homicides is actually quite higher than the numbers we see overall in our investigations. Of all the deaths we investigate, less than 1% are homicides, but here up to 10% in pregnant persons. And I think that just speaks again to intimate partner violence and the higher risk that occurs in pregnancy. The suicide rate is a little bit higher than what we see overall, and that kind of takes away the mythology that we've, I think, been told over the years, that pregnancy is somehow a preventive factor in suicide. But you can see a substantial number of the deaths during pregnancy were suicides. Undetermined means either there's not enough data or there's competing data to determine what the manner is. So was it an accident or was it suicide? Was it homicide or was it an accident? We're not sure. We're calling it undetermined. So that's where undetermined comes from. Now looking at the postpartum period, purple up to 2 days postpartum, orange up to between 3 and 40 days postpartum, and pale blue 43 to 365 days postpartum. And you can see the numbers are increasing for postpartum deaths. Part of it, again, is substance toxicity, unfortunately. And the numbers of the late postpartum deaths, we may be missing quite a few, because if they died, for example, of cancer and somebody forgot to check off that they were pregnant, we might not have seen it. And we were not looking at natural deaths out to a year postpartum until 2023. So after this data was collected. So when I show you this next breakdown, it might explain a little bit why these pie charts look a little different. So less than two days after the baby's born or the pregnancy has ended, majority natural. You've heard from Anne what those causes of death are. And then we have this little piece of the pie, which is accident. Same thing with 3 days to 42 days postpartum. And then we get into the late postpartum, and you can see we as coroners look at all the non-natural deaths. So it's not surprising that we'll have all the data for the non-natural and we're missing a bit of the natural deaths. But it is still quite remarkable, the percentage of the postpartum deaths that are suicides. And again, this accident, 25%, that's a little bit less than the overall accident rate we see for our populations that we investigate as a whole. But all 25% substance toxicity deaths. So here are some factors that we've seen related to pregnancy and postpartum. Again, Anne's talked a little bit about this. The things I wanted to flag are colored in yellow there. You can see that during pregnancy, associated with that, no prenatal care, rurality, lack of access to care, and being precariously housed. We put homeless, in a shelter, couch surfing, living in a car, they're all considered precariously housed, so grouped together. And you can see that no prenatal care is associated with a substantial number of people who died 2 days postpartum. Looking at out a little bit further, still important, rurality and precarious housing. And again, we see that we match with Bourne's data of the average age being around 31. So now we're going to talk about specific cases and how the further information we've gotten from the Obstetrics and Perinatal Death Review Committee. I want to flag that when these individual reviews are done, we get all the health records, we get police records if they exist, post-mortem report if a post-mortem was done. Often we will get letters and statements from families considering their issues, and the coroner speaks to the families and the healthcare providers to get more information. So it's a robust collection of information, but unfortunately our data collection from the info they were putting in wasn't that great until around 3 or 4 years ago. Now we have epidemiologists who are on staff at the Office of Chief Coroner, and we've got a database that collects more carefully this data that's so important for all of us. So here's the breakdown of the common factors of deaths during pregnancy and the postpartum period. Again, substance use. Almost 10% of the deaths during pregnancy and the postpartum period were related to substance use toxicity. It was the cause of death. Other known high-risk pregnancies, this is not a surprise. Points of intervention. A good number of them were involved with child protection services, and that can be either their children were involved with child protection or they themselves, the childbearing person, was under the care of Children's Aid or connected with Children's Aid because they were a younger person having a pregnancy. Mental health diagnosis, they have had, that means there was a pre-existing mental health diagnosis, so an intersection with healthcare practitioners who made that diagnosis. And of course, domestic violence, intimate partner violence, as we talked about, the lack of prenatal care and precarious housing, all really important things. So when we were looking at these cases, we decided to tease out some of the topics so that we could understand them a little bit better. And we're going to be doing deeper dives in the next few years. There's one that I'm going to talk about right now, substance toxicity, where the report will be out in the next few months. And then we'll be talking about free birthing. That report should come out next year, and the rest will follow. So let's look at substance use. So substance use deaths, this is where it is we'll call it recreational substance use caused the death. It's not complications of chronic use. It's not because somebody else poisoned them or that it was a suicide. This is specifically substance use toxicity in somebody who's using substances on a reasonably regular basis. Purple is pregnancy, orange is postpartum, and you can see that the numbers, although small, are going up. And the thing that concerned us was seeing this purple bit, deaths in pregnancy due to substance toxicity. So we looked into that a little bit more deeply. And here's what we found. Again, purple is during pregnancy, orange is during the postpartum period. So you see that almost a quarter of the people who died of substance toxicity were precariously housed. That 17% of them had no prenatal care. That around a third of those who died in pregnancy of substance use toxicity or postpartum for substance use toxicity had used at some point opioid agonist therapy. And that is interesting because it means that they have sought out care before, that there was intersections with the healthcare community. At the time of death, though, the vast majority were not using opioid agonist therapy. And you'll see that in the postpartum group here, exactly a third had a recent relapse of substance use. And as we looked further into the health records, it was quite obvious that they were doing their best to stay off substances during the pregnancy. But after the pregnancy was over, that's when the risk kicked in. And as well, you'll see here the involvement with child protection agencies, a quarter in the postpartum. That could be because the children are under care or have been involved, or again, as I said, the person themselves is involved with that. Again, we see a high percentage of domestic violence in both the pregnant population and the postpartum population who die from substance toxicity. And I'm flagging all of these because it, number one, leads us to the understanding that holistic care, wraparound care, needs to address all these issues. And also that that nothing is in isolation, right? We need to, these are issues that overlap into each other. So here is the mental health. So these are suicides. These are not undetermineds, we're not sure. These are the ones where we know that it was a suicide. Purple, again, pregnancy. Orange is the postpartum group. And although there is this bit of a rise here, there is no real trend that we're seeing with mental health deaths. So you can see purple, pregnancy, orange, postpartum. So half of the people who died of suicide during their pregnancy had a pre-existing mental health disorder. Could be anxiety, could be depression, could be bipolar. There's a variety of different diagnoses that were made. 75% or close to 3/4 of the postpartum suicides had a pre-existing mental health diagnosis. And again, what this means is that these people have intersected with healthcare. They have had identified healthcare issues related to their mental state. They have died of suicide. This is not to determine, this is not a predictive model. This is an associative model. So just to make that very clear. Previous suicide attempts, over a third of those who suicided in pregnancy had made attempts prior, and there is a good number as well in those who are postpartum. And then a quarter of the pregnant population that died of suicide had involvement with child protection and had a history of substance use. So it's this intersectionality. Somebody who is a substance user, often mental health associated, often concerns related to suicide as well. So now we're going to change gears a little bit, and I'm going to share some aha moments that we had when we were going through our data and we were receiving referrals for death investigations. Unattended births, another term for this would be free birthing. This is when somebody decides that they are pregnant. Everybody knows they're pregnant, but they've decided not to have a healthcare practitioner, either a midwife or a physician or anybody of that sort, care for them during pregnancy or at delivery. And we saw a few of those referred to our committee before 2020. but then it just took off. Again, small numbers, so we weren't quite sure what that meant, but I can tell you there were more in 2023 and 2024 that we're gathering and analyzing. So what's up with that? We went to the registrar and we said, how can we see if there's an increase in free birthing across Ontario? And they were able to provide us information using birth registration. When a birth is registered, you need to say who delivered the baby. So here's the trends for physicians delivering the baby. Here's the trends for a midwife delivering the baby over the years. And here's the trends where there's nobody there. So you can see there was always a baseline population, but it really took off 2017 and then really peaked after 2020. And in the ones that we are looking at right now, part related to COVID, your partner is not allowed to be at the delivery because they're not vaccinated or they're not wearing a mask. I'm not going to deliver in the hospital. I'm not going to deliver with a healthcare provider. Or I've had a very bad experience in childbirth before, and I want to take control of my childbirthing experience and my pregnancy experience. Those are the trends that we're seeing right now. We are working on a research on that right now, and we should have information where we've interviewed families that have been involved in the free birthing experience so that we understand it better and can put this data into perspective. Concealed births, not the same as free birthing. Concealed births is when you are pregnant, but you may not realize you're pregnant, and certainly nobody else knows you're pregnant. And then afterwards, there is childbirth occurs. So blue is a natural death. These are for the infants that are born, by the way. Green is undetermined. Purple means accident, and orange means homicide. So that's the trending of concealed births. And we'll talk a little bit about how those are broken down. And you say, why so many undetermined? Because these infants are found hours, days, months, and sometimes a year after they were delivered. And so we can't tell what the cause of death is because of decomposition, or we can't tell if they were born alive or if they were a stillbirth because of decomposition occurring. So here's the breakdown for these groups. Quite a few are under age 20, and that group connects with living with parents, the bottom one there, that's almost a third of the population. And the story with these is a person presents to their parents and says, I'm bleeding. They're brought to the hospital. A healthcare professional says, looks like you've had a baby. Where's the baby? And then you go back home and you start looking for the baby. Others, a known history of substance use. Others, more than 50%, it's high material deprivation. A good number are involved with child protection as well. And as you can see, over a quarter, almost a third, are precariously housed. So substance use toxicity, the use of substances and precariously housed often go together. And often unfortunately, the infant is born while the parent is intoxicated. And it's somebody else who notices that there is a baby there. So again, this is just information to share with you so that you're aware. So last piece is, what do we do with our recommendations? We talked about having over 200 deaths that were reviewed and over 350 recommendations. And here are the types of recommendations that come out of these individual reviews and sometimes going into systemic reviews. Institutional operations and oversight, recommendations like every hospital should have a postpartum hemorrhage protocol in place, that there should be a code called for massive transfusion, and it should be in place for this particular hospital or other hospitals as well. Policies, procedures, and guidelines, recommendations to the Society of Obstetricians and Gynecologists that they have a best practice guideline for morbid obesity in pregnancy, as one example. Communications and collaboration, communications during transfer of care, communication in documentation, communication to families or to the person who is having the baby, all those types of recommendations as to how we can improve on that. Person transfer and transport, would be emergency department, paramedic transport between institutions, education, training, resources. We release all of our reports in a redacted form to use for teaching purposes for midwives, nurses, physicians, anybody who's interested. And please, if you folks are interested, more than happy to please do contact us. And then finally, committee and case specific. For example, the family should all be tested for the specific genetic disease that's been discovered, or the mother should have be followed by a high risk pregnancy unit for the next, because we've seen what the cause of the stillbirth or neonatal death was. So that sort of thing. So in summary, many deaths during pregnancy and postpartum are preventable. I think Anne and I both said that to you a few times and believe it strongly. These deaths, along with stillbirths and neonatal deaths, can provide insights and recommendations to prevent further deaths. We've improved our data collection with epidemiologists and our database, so we should be looking even deeper into the social, economic, and geographic aspects of deaths that we review. We've seen the relationship between pregnancy, perinatal deaths, and rurality, material deprivation, and housing instability. And these are all things that we hope with public health will be able to be addressed. And finally, we are collecting race as a mandatory realm, and have increased our investigative templates to gather more data. And we're hoping that we'll get more information coming out of that very soon.
So I'm going to just talk just very briefly about the public health implications. You know, we were asked to present to a public health group. So I think you heard in this presentation how important substance abuse is. And I think you all know that, you know, in your own areas, your populations that you work with. But it is an ongoing problem, and certainly in the realm of public health. Bourne and the OPDRC both found you know, large numbers of deaths associated with substance abuse. Mental health, again, Louise talked about it, I talked about it. Many people had mental health concerns during their pregnancy. We had suicides, and Louise's group found that, you know, 5.8% of individuals had a pre-existing mental health diagnosis, and 4.4% had intimate partner violence. So mental health is an area, and substance abuse. And then finally, prenatal education. How do we get this information to those planning pregnancy? You're certainly not going to talk about, you know, you may die in the prenatal class. And I have to tell you, when we were doing our work here, one of our epidemiologists who was doing much of the analysis on this was pregnant, and what a horrible thing to have to deal with when you're pregnant. And now one of our research coordinators working on this is pregnant. So, you know, it's a tough thing to talk about, but certainly we want to make sure that people understand the relationship between substance abuse, precarious housing, mental health issues with pregnancy outcome. And it may not be death, it may be morbidity, but it is important to talk about. So we want to partner with public health on these initiatives. And so just now we are happy to answer your questions, but the idea here is that, you know, there are fractured families left behind, and we want to work on prevention strategies in partnership across the province. So whatever we can do, and whatever information we can help provide to public health or to other groups, we're happy to do so. So I'm going to pass it back to Ruth, who can facilitate the question and answer.
Great. Thank you so much, Anne and Louise, for that really interesting presentation. So we'll now move into the Q&A segment, and we'll answer some questions from our live audience. So we do have several questions coming in. So I will start with one directed towards Anne. So are there any particular types of cancer-related deaths or changes over time in cancer-related deaths in relation to maternal mortality?
We didn't take a deep dive into cancer yet. I can certainly remember The one pregnancy-related cancer was a choriocarcinoma, so I remember that. And then the other cancers were just a mix of what you'd expect, for women's cancers. There was certainly breast cancer, there was bowel, there were some lung, there was some hepatobiliary, but I don't remember specifically numbers. We'd have to go back and look at that. But I don't remember there being a specific pattern of cancers. And I don't know if, I looked at the other question, I don't know if there was a change in cancer over time yet, because we haven't done a deeper dive into that yet.
Louise, did you want to add?
Yeah, was just going to say that in some of the cases that we've been looking at for those deaths, it's often related to the pregnancy though, because it's the cancer is diagnosed during the pregnancy and then is treated later. And usually in the postpartum state, we've had many cases where the mom is just exhausted and says, give it a couple more months and then I'll deal with this. And we see the deaths from cancer afterwards. So pregnancy is impacts these cancer deaths from the ones that we've looked at.
Wonderful. Thank you so much. Another several questions have come in regards to some of these mental health factors that play into maternal mortality. So, directed at Louise, are there any mental health experts on the review committee? And are mental health diagnoses generally known to care providers, or is this something that's not screened for? And how might we improve care to address some of these things?
Great questions. First thing is, in the committee itself, there is not, but that is one of the subcommittees that we're planning right now. I've reached out, there's quite a few, I was surprised to find out, as you heard, I'm not an OB person. I've been learning a lot as I chair this committee. And I've reached out to a few groups that specialize in mental health care of pregnant and postpartum persons, where the availability of that care depends on where you live. With some of the conversations that I've had, if you live in a city like Toronto, you've got a higher likelihood of being able to get connected with somebody who really is in that sphere and can give you that type of analysis and help. But if you're living up in Timmins, or if you're living in Dryden, or if you're living in Sault Ste. Marie, you might not get the same care. So that's just something that we've flagged. We've got these people that we're going to be bringing into the subgroup to do that subgroup analysis. We're not there yet, but thank you for asking, because it is important to have the right people around the table.
Thank you. So this actually is a great segue into this next question that focuses on access to care and its relationship to maternal mortality. And is there any data or any information that can address how this might play out for certain populations, such as the immigrant or refugee population, anything to do with citizenship, or other groups such as rural and remote or indigenous populations?
Do you want to start, Anne, or would you like me to go?
Go ahead.
Okay, so in our new templates for maternal deaths, neonatal deaths, stillbirths, that sort of thing, we're actually asking, where were your parents born? Where were you born? Are you a Canadian citizen? Are you not? And then going through racial identity. And we all know that, race is a construct. But we get information from the family as well as other information to help figure out what the race is. So the question is, do we have it now? No, we don't. But we've got these new templates that we've just started using in the past year to try and tease that out. Also, language. Are you able to speak one of the two official languages in Canada or not? And as well as other pieces that we're going to be collecting. Anne, did you want to say anything?
I mean, you don't want to get me on my soapbox about collecting data. I mean, it's incredibly important for us to collect specific data, either about people's self-identified race, but without it, we can't count. We don't know. And there is a hesitation from healthcare providers and from individuals about why people are asking about race. And you know, there have been abuses in the past with people using data the wrong way. But at this point in time, we know the importance of sociodeterminants of health. We know how important it is to be able to be able to understand what's happening among racial groups and get help that people need. So if we don't collect it, we're never going to be able to find the answers to these questions. So we have to improve across the healthcare system.
Excellent, thank you. So we only have 5 minutes left, so we may be able to address a couple more shorter questions, but I'll let you know there is plenty of interest and questions in this data and in this topic. So are you able to know in any of the data that has been discussed today, when during the pregnancy the death occurred? So this is related specifically to deaths during the pregnancy and not in the post-birth period. So is there a way to determine whether these things happen early versus late in the pregnancy?
Yeah, we can tell from the data because we can get a date of death, and we already, if we're, if we've linked well to the sites, we can tell, or the other data sets, we can tell, from backdating from when the delivery was, or when the death was, or when the due date was. We can figure it out for sure.
And from a coroner's perspective, many of these do get autopsies. And sometimes we are surprised to find out they're pregnant. The family was not aware they were pregnant, but they would have been aware that they were pregnant as we're going further in the records. And so do we know the average gestation was 20 weeks for the deaths in pregnancy? So some were early on. Quite a few of the suicides were in the first trimester going into the second trimester. So yes, we're able to go back and find that out. I can tell you we're probably missing some of them because sometimes we will do what's called an external examination, say for hangings, for gunshot deaths that are self-inflicted, and they can be pregnant and we don't know. And we've asked if we can do a beta HCG and all women of childbearing age when they die of suicide and externals done. We haven't moved that forward yet. We haven't got there yet, but that's what we'd like to do.
Great. And one more that goes back to the pre-existing mental health diagnoses, is that seems to be a large indicator or factor contributing to suicide deaths during pregnancy. Was there any information on the breakdown of particular diagnoses? I know you said it could be many different ones, depression, anxiety, bipolar, but is there any that are particularly, I guess, risky?
Okay, so risky is a tough one because again, this is not a predictive model. This is an associative model. So how many women of childbearing age have had a diagnosis of anxiety? How many have had a diagnosis of depression? That sort of thing. We just know that it's associated. The substance toxicity group that we've been working on for deaths in pregnancy, our report should be out in the next month or two. And we've got a breakdown of all the mental health diagnoses that were connected with it. But so I wouldn't want to quote right now any numbers, and that's specifically related to substance use toxicity. But yes, we do look for the actual diagnosis. The most common, if I remember correctly, anxiety and depression.
That's what we know from the Born Information System as well. I know we have to wrap up, but we do collect that in the Born Information System. And so with more data linkages, we could look deeper into that. But certainly there are a list of diagnoses that is in the Born Information System that we can look at with mental health.
Wonderful. Thank you so much, Anne and Louise. This was very insightful and very educational. And I'd like to also thank everyone who joined us for today's event. You can expect to receive a brief and anonymous survey for today's session. Please try to complete it as it does help us improve our programming. And thank you so much again, and have a wonderful day, everybody.